And I'll just turn to the McMaster students. You guys just let me know when you want to kick things off. Guys, no pressure, but please feel free to come off, yeah, to put yourselves on camera. Sometimes it just makes it feel like we're really in a room together as opposed to just talking to a screen. So Kaden and Haroon, I really appreciate that. Don't worry if you decide to go off camera later on, we won't call you out, but it's nice to see your faces. Hi, Sarah, lovely to see you as well.
We're just letting a few more people in from the waiting room.
Okay, sounds good.
Thank you for having us. Excited to be here today.
Yeah, where are you, Sarah?
I'm at home right now
In which city or town?
in Toronto.
In Toronto. Okay, it's
Yes.
cold, eh?
It's so cold, but there is sunshine, so cannot
Yeah,
complain. Hopefully it gets a bit warmer in the next few days.
I don't mind the extreme colds, but it's definitely something. It's
Where are
definitely.
you now?
I'm also in Toronto, but I will
Mm.
say it's the first time I was just walking home from an in-person meeting and uh, tried to send a text message while walking, and it was impossible. So that's my like threshold for it's really cold, and we've reached that. Having said that, I work with someone in Saskatchewan, and he was telling me the last time we connected, he was like, "Oh, it's negative 52 out." So I know, I know. But why don't we, just for the sake of time, is it okay if we kind of kick things off and get started? Awesome. So thank you guys so much for joining us all today. Um, I want to just say a big welcome to the PIH, MIGH panel on tuberculosis beyond the textbooks, gaps, innovation, and health systems reality. As is always the case, we're going to do some quick intros to get started. And I also just want to note, if you didn't see it when you came in, that this panel is going to be recorded. Okay. The one other piece I'm going to say right from the start is that I get excited when I talk and I can speak very, very quickly. If I'm speaking too quickly, please just say it. You can even interrupt me. That's totally fine. We want you guys to get the most out of it, and that involves hearing what we are all saying. So my name is Marley Austin, and I am the Director of Programs and Partnerships at Partners in Health Canada. So PIH, as we call ourselves, we're a global health and social justice organization. We're founded in 1987, both in Haiti and in Boston in the United States. And our focus has been on providing high quality. And by high quality, we mean like the best available quality, the same kind of quality that you can get in the elite institutions, elite hospitals in Toronto, also in Boston. So we're focused on that comprehensive healthcare, and our real focus is on the poor and the marginalized. So at PIH, we address root causes of illness. We do this by building local capacity, by strengthening health systems, by training local staff, and ensuring access to essential medicines and the services. That includes in-home care through this robust network of community health workers that we have in every place where we work for diseases like HIV and tuberculosis, which we'll be talking about a lot more today. So today's panel, it's in partnership with the Medical Innovation and Global Health Association at McMaster. And I'm going to pass over to them for a quick intro and a little bit of housekeeping.
So thank you so much, Marley. Hi, everyone. I'm Sonika, and I'm the president of the Medical Innovation and Global Health Association, otherwise known as MI at McMaster this year. I'm currently completing my MSc in the Global Health Program with a focus on the global burden of disease, challenges, and changes stream.
Right. Hi, everyone. I'm Verena. I'm also part of MI. I'm the VP of competitions at MI. I'm currently in the Global Health Masters program as well. Just like Sonica, I'm specializing in burden of disease. And then I'm going to pass it over to Sonica just to go over some quick introductions about the club and quick housekeeping, and then we'll get right into the panel.
So MI was actually first founded in August of 2024, and we wanted to create a space to foster cross-faculty collaboration among graduate students in business, engineering, and the health sciences. So our goal is to kind of equip young professionals who are passionate about healthcare to foster creative problem solving and thinking so that we're able to address global healthcare challenges. So that led us to wanting to facilitate a case competition with the support of PIH Canada. And just a special thank you to Allison and Zaina for all their help in the months leading up to this competition. We really could not have done it without you guys.
All right, so we're going to begin shortly the panel and going to follow it up by a quick Q&A. If you please stay after the panel if you've already signed up for the case competition, if you've already registered on Eventbrite. But also if you're interested in signing up, you can stay behind after the panel. We're going to be sharing some quick important information. This panel was opened for the public, so it is also part of our 2026 case comp. That's why I'm giving a little shout out to everyone that's going to be staying after. If you're interested in signing up, I think we're going to pop a link in the chat now. And if you're a participant and you want to receive a certificate for attending, if you could please have your cameras on so that we can hand out those certificates later for people that are attending and engaged. All right, I'm going to hand it over to Marley so that we can officially start the panel.
Thanks, guys. Thanks so much. And just to kick things off and say thank you for organizing this event. And you have all been tremendous organizers, collaborators. So it's great. I also just want to say case competitions are super fun. So amongst all of the important learning and team building that you'll get, they're great. They're awesome opportunities. Strongly encourage you all to sign up and stick around to learn more about them. So one final thing, guys, please turn your cameras on. Make it feel like we're in a room. No pressure, but if you want to, it would be great. So our panel discussion. This isn't going to be a discussion that's limited to a single region, a single disease area, or innovation theme. The TB case competition, it will focus on TB, as the name implies, but this panel, we're really looking at the broader landscape of global health work. So we're going to touch on things like international development, health systems research, infectious disease, and some of the realities that come with working in low and high resource settings, and also the realities of like not exclusively working in those settings and some of the insights that you get from having exposure to both. The panelists, I'll introduce you to them shortly. They're invited to share their lived experience from the field, really including the challenges they face, the successes they're proud of, all those lessons. We really want them to give honest reflections and also guidance to students. Things like what you wish you had known earlier, how to navigate uncertainty in global health, and critically, and this is where I think the PIH approach is so relevant. It's how do you approach this work with humility, real resilience, and impact? But let's center the humility in all aspects of it. All right, so I'm going to introduce the panelists. I'm going to begin, and maybe if you just want to like quickly come off mute and say a quick hello, that'd be awesome. So first off, we have Dr. Charity Oga-Omenka. Charity, you want to give us a quick hi?
Everyone, lovely to be here.
Awesome. So Dr. Charity is an assistant professor and global health researcher at the School of Public Health Sciences at the University of Waterloo. She serves on the World Health Organization's Steering Committee for Tuberculosis, or TB, Public-Private Mix Working Group, the Science Translation for Health Emergencies Community. Her mixed methods research aims to impact policies and practices to optimize tuberculosis care. And I think we're going to have some interesting discussions on what it means to optimize that care. So welcome, Dr. Oga-Omenka, and thanks for joining. Next up, we are going to Dr. Dawit Wolday. Dr. Wolday, do you like to just say hello? So Dr. Wolday, many of you, I'm sure, know him from McMaster. He's an assistant professor in the Department of Biochemistry and Biomedical Sciences. His research links the complex understanding of immunology and clinical investigation and global health implementation science by studying the interactions of hosts and pathogens and immune activation. His work on improving the capacity to treat infectious diseases in underserved regions enhances clinical decision-making on a global scale. So welcome, Dr. Wolday. Next, I would like to introduce Dr. Ferris Munyonho. Dr. Munyonho, would you like to say a quick hi?
Hi.
So, Dr. Munyonho is a postdoctoral researcher at McMaster Bowdish Lab in the Faculty of Health Sciences. His groundbreaking research on, and apologies if I'm, bear with me, listen,
Pneumocystis.
pneumocystis pneumonia. Did I get that right?
Right.
There we
Yes.
go. So it's a fatal lung infection. It's furthered the field of respiratory and infectious disease research, particularly reducing the demand on healthcare infrastructure in his home country of Zimbabwe. I'm really hoping to hear more about that. So thank you and welcome. And
Thank you for having me.
last but not least, we have Petra Heitkamp. Petra who directs iLink2, a social enterprise building community health solutions. She's also director of the TB Public-Private Mixed Learning Network. This is it's an international community that's dedicated to enhancing timely, dynamic, effective TB prevention and care by engaging the private sector service delivery. Petra is also the co-chair of Stop TB Canada. She has nearly 25 years experience in the global health field, and she has focused on how collaborative approaches and community empowerment can advance interventions for TB treatment. So thank you, Petra. Do you want to say a quick hello?
Hi, everyone. Nice to be here.
Wonderful. Okay, so I need to stop talking. I want us to really ensure that we are starting off any conversation about something as horrible as tuberculosis with the idea of the people in our minds. Let's center this on the people who are affected by tuberculosis, either directly or indirectly. Because when we are seated at our computers in Canada, it is so easy to just deal with the sanitized numbers and not have the emotional impact of it. So I'd like each of our panelists to share something about someone whose experience with tuberculosis. Now, again, this can be direct or indirect, that motivates you to do this work. And we're going to kind of go in the reverse order. So Petra, we'll begin with you.
Great. Yes, thank you. Well, my experience with tuberculosis started many years ago when I was just done with my master's degree in public health myself, and I spent a year and a half in India working with an NGO that was really embedded in local primary care systems. And one of the issues that I kept running into when I went to villages was people coughing and not having any solutions for it. And the colleague that I was working with was really giving me a very clear outline of what the problem was around tuberculosis, how unacceptable it is that we actually have the cures and the tools, and that nothing is actually accessible for the people in many of these villages, that they're just simply not having access to the tools that could cure them and could eventually kind of cure the whole village. So that injustice, that complete lack of access for so many people was something that stuck in my mind. And since then, I've been looking at tuberculosis as an issue to really look at inequitable health systems. So for me, it is a driver of, you can clearly see that TB falls in those people that fall in the cracks of systems, and those people that are marginalized, those people that have not access to healthcare, those people that are often poor but not always. And I think that if we can deal with TB, we can actually create systems that are accessing basically everyone that needs healthcare. So I think I'll leave it at that for now, but there's a lot more that I can share around these issues.
That's awesome. And I think you've hit on right from the start a really important note, which is that so many of the solutions do exist, but so many people don't have access to them. So we'll dig into this a little bit more. Ferris, if you'd like to share.
Right. Thank you. My motivation is deeply personal. I was born and raised in Zimbabwe, which is located in sub-Saharan Africa, and where infectious diseases like TB, HIV, and AIDS, malaria are part of a daily living. So my mother, for instance, got infected with TB when she was pregnant with my brother. And I remember at that time she had to be admitted in the hospital for 3 months after she delivered the baby. And for those 3 months, my elder sisters would need to take my brother back and forth every single day to the hospital for breastfeeding. So those memories, like of nights that I would sleep, although I was young, imagining whether my mom is coming back, and even beyond my mother, just seeing close relatives and friends suffering and at some instances die from TB, it stayed with me. And as traumatizing as it was, it also became the foundation which spurred into a career in biomedical research. And, the thing was, people didn't die because treatment doesn't exist, but just because they were unavailable, they were delayed, or they were inaccessible. So that was the case. So for me, I became pushed to become part of the solution rather than witness a preventable problem.
That's really, thank you for sharing that. That must have been very, very difficult. I think I would take comfort from a story like that if I knew things had changed. But I do believe that in so much of the world that remains a story that's repeated over and over and over again. And just to really like hone in the point, the cure is not recent. It has been around for decades and decades. And so it's an injustice anytime someone dies from tuberculosis. Dr. Wolday.
Thank you. My story is somewhat similar. Can you hear me?
Yes, we can. Thanks.
Wonderful. Yeah, my story is somewhat similar, and I was born and raised in Ethiopia. Grew up in an area where TB is rampant. Then, when I completed my medical school studies in Ethiopia, I was a young physician, fresh out of the medical school, with a lot of information that I gathered from textbooks, reading, and so on. Very little clinical experience. And then I was assigned in a very small rural hospital in Ethiopia, northern part of Ethiopia, indeed. And I treated a 7-year-old man with severe tuberculosis. After doing chest X-rays, put him FB, and so on, then once it was confirmed with TB, I started with anti-TB medications. And my advice to this 70-year-old man was, you should take a high-protein diet, such as eggs, meat, dairy products, and so on. This was like a textbook recommendation, okay? Then the patient returned to me with a look of surprise and a half smile. Then he said, Doctor, if I had access to this food you listed, I would never have needed your help and medical attention. And I was really stunned. And he was right. Tuberculosis, affects individuals with a very low immune status, such as malnutrition, like in the guy. And I learned my first lesson from a patient. From this day onwards, I really become interested in immunology. Why we become sick? Then I did pursue my PhD in Karolinska Institute in Sweden, worked for the next 25 years, 30 years in Ethiopia, arrived recently in Canada, still continue to work in infectious diseases, including emerging infection, with a lot of capacity building in Africa. I was engaged, including the most recent Marburg fever outbreak that happened last November in Ethiopia. Thank you.
These are great stories. Again, thanks for sharing. One of the things that we at PH fight for is we view food as medicine, because so often people are getting sick and they are coming for clinical treatment, but really at the heart of it, it's these really like upstream causes, like they don't have enough food, they don't have access to clean water, they don't have good sanitation. And these are things that ultimately the healthcare system treats, but the healthcare system, other things need to be addressed. Thank you very much for that story. Dr. Charity.
My experience with TB goes a long way back to 2011 when I was a younger pharmacist working with Global Public Health NGO in Nigeria. And where I had trained as a pharmacist. And I was responsible for ensuring, first and foremost, to write the grant to the Global Health. That was the core team of 5 people that wrote the grant to the Global Health that subsequently won that round for drug-resistant TB. So I managed the logistics, health logistics part of it, making sure the lab products and the medicines got in, and we had to use some estimation because it was more or less new work to estimate how many patients we're going to have and then plan for that. And so very early on, some of the problems we saw at the time was that the medications we brought in, expecting X number of patients, we were not seeing them. And I began to wonder, like, was there a mismatch in the WHO estimates, and why are we not seeing the patients? We had the products, we were taking them to public health organizations like hospitals, we were taking them to, public health hospitals, I mean, like teaching hospitals, secondary level hospitals, a very few primary healthcare hospitals at the time because, it's a new program. And so we're just bringing those medications and lab equipment and looking for patients, and the patients were not there. And well, some of them were, but not enough to the number that we had planned. And we started very early on seeing very expensive lab reagents and medicines expire. And then as a pharmacist, you couldn't just destroy them. We had to go through a whole protocol again. And then seeing the dollar amount to all of these processes was really frustrating. Why are we bringing in all these hundreds of thousands of medications and then maybe half of them are used? So immediately I started thinking, but then when the patients started using it, first, some of the problems I started seeing were patients really reacting to the second line medications at the time, some wishing for death rather than being injected with those very painful second line medications of the time, that you will see people crying, like mature men and women weeping when they saw the nurses coming with the medications. I was like, what kind of medication pushes patients to their limits? Pain in pain management like this. These were some of the early questions I had at the time. And then fast forward to 2-3 years later, I immigrated to Canada to start my PhD, this time around as a researcher. And I went back again to the same program and interviewed patients. One story that would always stay in my mind and has influenced a lot of work that I do today is that of a young woman. We were interviewing her. She had been diagnosed with drug-resistant TB. And remember that we're not finding enough patients, right? So we had got, for my PhD, because I had been working with the country for long, we're part of the initial team. I knew who to go to. So I had gotten to the National TB program and gotten a list of patients that had been identified as having drug-resistant TB, but we are not on treatment. So we decided to interview some of them. Getting to them was really difficult, but finally we got to a few of them, and that we're not on treatment. And I wanted to know why. Why are you not on treatment? And this lady said, okay, she's going to talk with us. So my research assistant, someone in Nigeria at the time, helped me set up the time. And the time of the interview, this woman starts to speak, more or less saying, oh yeah, she recognizes the need for treatment and whatnot. And not even 3 minutes into the call, there was a tussle. We could hear sounds on the phone because it was a phone interview. And then a voice just shouted into the phone, "This is my daughter. I have told you guys not to contact her again. We do not want her to take medication. And we believe that she has been prayed for and she has been healed. And we have warned all of you never contact her again." I was like, oh my gosh. So there are female patients, adults, this woman was in her 20s, that are being prevented from taking treatment for a very life-threatening drug-resistant TB. It kills. And a father is preventing his daughter that wants to take treatment because of his own beliefs. I was shocked. I was really shocked because no one at the time could really tell why some patients were not coming to take their treatment. We would find out, and also with help from the national program, that other patients, it could be a child and the parents don't believe in that. In biomedical treatment, they were going to take them to traditional healers. It could be someone that said, oh, no, my faith does not allow me to do this. It could be there were some men that were breadwinners and they couldn't afford to take the time to go to the hospital, because at that time you had to be, for drug-resistant TB, you had to be on admission in the hospital for 6 months. And he's like, who's going to take care of my family? I can lose everything. I can lose my livelihood, lose my family in that 6 months. So I'd rather live the rest of my days with my family than go to a treatment center and lose it all. So these kinds of patient experiences really stuck with me and have been deeply, deeply influential in what I do today.
I think it's often such an important recognition that
Yeah.
when you're at a distance from a medical problem, your inclination is to think about a technology that will save it, and that the innovation that is needed to make the difference is something that you can hold in your hands or that you can point to and see. And often it is about navigating power and relationships within a community. And one kind of thing that comes to mind is often with these diseases that we have neglected so often, and I don't know if this is the case in the community that you're talking about, but what has happened is that there is no trust that exists within the community for the health system's ability to solve a problem. And so hospitals can sometimes be viewed as places that kill people, because that is where people go and that is where they die. And so we would say, from our experience, maybe in the Canadian context, no, like they went when they were too sick, it was too late. And so there was no time for the intervention. They died when they got there. But it's very easy to understand how that can be interpreted as hospitals, healthcare workers, they kill people. And if it's a disease like tuberculosis, where the treatment is hard, you mentioned that, Charity, in what you were saying, they're not necessarily going to want to do it. And maybe they do it for a few days, they get a little bit better, and then they stop. And we can recognize that as something that causes more problems. Because you get more resistance and it's harder to treat, and then it comes back. But the way these narratives that exist around disease are so powerful, and for infectious diseases across the world, addressing them requires as much, if not more, effort sometimes than the other types of innovations that I think we'll get into today. So grateful for that. I think we're going to shift to another question. And what I want to really get at is this idea of the diversity of experiences you guys bring. And in the answers that you've already spoken about, I think we're getting a sense of that. But maybe, Petra, I'll start with you. Can you talk about the diversity of experiences, but also, so like the differences and the similarities that you see in the patient experience in different parts of the world? If that makes so, differences and similarities, maybe if you take the Canadian context, whatever 2 contexts or 3 that you want to speak to. Thanks.
Yeah, thank you. And I think you're rightly pointing it out there. There are clear differences, but let me start maybe by saying that one of the similarities is that we're not people-centered enough. We're looking at the bacteria and we're trying to treat the disease instead of looking at a human with a health issue. So TB is biologically obviously the same all around the world, but patients' experiences are really, really different depending on the location, depending on the context where they live in, depending on what their socioeconomic situation is, what the cultural context is, and I think you've heard some great examples. So that then implies that there is a complete difference in how people are being screened or diagnosed, what their access is to care, very different in terms of costs that are related to that, the availability of support and treatment, the financial burden. They're very different, and you can give concrete examples from someone who is living in an urban slum in India or in an urban situation in Nigeria is very different from someone who is rurally in Nepal in the mountains in terms of access is a clear issue, but all of these issues are I think the similarities are, of course, in the biological part where you can see how the bacteria works within your body. But I think also for the human, it's the emotional stress. A lot of people sadly still face stigma, uncertainty, fatigue. These are kind of the physical and the emotional symptoms. And oftentimes, even I think many people are being treated, when you talk about a country like Canada, who are able to find access to treatment, still they feel overlooked by the health system because it is such a neglected issue. So I think what we want, and I come back to that patient-centeredness, we want people to be treated and to be believed and to listen to and treated with dignity, and for everyone to have access to timely and respectful care. And I think that's often really what is still missing in the multiple contexts. And sadly, I wish it wasn't the case, but I would say that that is one of the areas that we really need to work on. That's one of the similarities.
Thank you so much. I'm going to pivot over, and just for the sake of our panelists, I'm going to keep the questions dynamic. So I might not be asking you all the questions that you had originally been told you would, but we'll go over to Dr. Wolday. I'm interested in your answer to that question as well.
Thank you. Yeah, having worked in Ethiopia with TB, I have been running TB clinic for 2 years after my graduation when I moved from the rural area to the city. So I have a lot of exposure with patients in Ethiopia. Like if you test my PPD up until recently, I migrated to Canada. It's very huge, so like 4 centimeters because of the exposure. Then I have seen, and recently joining Canadian academic environment, I have seen, both structural conditions as well as, different situations that shape both vulnerability as well as care pathways. In low-income countries, patients often present very late to clinics, where there is a delay in diagnosis. It could be due to the availability of diagnosis, financial burdens, or other stigma, a major problem. The clinical encounter is frequently influenced by competing social, food insecurity, crowding, housing, need for to prioritize daily work over treatment, and so on. So these are the major challenge that we face in low-income settings. But despite this, the outcomes are still not bad. People are resilient with strong family support, as well as deep trust in frontline workers. In contrast, in high-income countries like Canada, patients will benefit from a very robust diagnostic systems, like universal health coverage, as well as good social support. Still, there are again challenges, even high-income countries like Canada, in particular among newcomers, migrants, as well as marginalized populations, and also among people, with other conditions, multimorbidity, comorbidity, HIV, and substance abuse, and so on. Across both contexts, I would say the core human experience of TB is shaped by fear, hope, and also the desire for dignity. What remains constant is the importance of empathetic communication, continuity of care, and the health system that recognize the social realities that the patients carry with them. Those are important things, I guess, from my own experience.
Thanks so much. You mentioned, and a few of the panelists have spoken about this idea of, effectively competing priorities. So at Partners in Health in Lesotho, we have a hospital that focuses exclusively on multi-drug resistant tuberculosis. And I got to visit it a couple years ago. One of the things that was striking to me, when people show up for treatment for multi-drug resistant tuberculosis, they, at least at this hospital, are very, very, very sick and very emaciated, color of the skin. It just shows someone who is struggling. And one of the things that I noticed is that I would say about 90% of the patients were men. And I was probing this, and I know there's definitely as is the case with all disease, there is a strong gender dimension to tuberculosis, but started asking questions. And one of the things that kept on coming up is that the structure in Lesotho is such that the men are the breadwinners, and they go to work in South Africa, often in mines, and they get sick there, and there's no health service nearby. And even if there is, there's the extent to which this is the main driver, you can debate, but like there's rising xenophobia in South Africa amongst people from Lesotho who are taking the mining jobs, and on it goes. And so these men wait and they wait and they wait and they wait until they have no other option but to return to Lesotho for care. And it's just it's like mind-boggling to see. But you realize that so much of who decides to get care, how they're able to access it, depends on the infrastructure that exists around it. If you have like disability payment or whatever, or your job is protected with sick leave, you have so many more options to avail yourself of a health system. So again, just speaking about the integrations that exist within a social support network. I'm going to go to our next question. We're going to go to Ferris. From your experience, what are the biggest gaps in the world regarding tuberculosis testing, diagnostics, treatments? Over to you. Speak to any of that.
Right. Thank you for bringing that question. I would like to mention that what I'm saying here is not because I've been working on TB, but it's just based on personal experiences. So those personal experiences I've gone through speak highly enough to the questions you're bringing up. So some of the biggest gaps, they are not just scientific, they are systemic. So they involve delayed diagnostics, especially in under-resourced areas. We have limited access to rapid diagnosis. I'll give you an example of where I'm coming from in Zimbabwe. In Zimbabwe, we didn't have a rapid diagnostic test like the Gene Expert until last year, very recent in June. That's when one lab was introduced, and it's only one lab in the capital city. So people could be tested using the traditional diagnostic methods, but those could detect TB, but they can't identify drug resistance, which you just talked about. So that means you get tested, you are positive, and then the next thing you are prescribed a drug that is inefficient to treat the kind of strain that you carry. So those people, they become reservoirs and they keep transmitting TB until the very end when they realize, oh, this patient is not responding to treatment. Let's try and see if they have the drug-resistant strain, and then they can be prescribed the drug-resistant TB drugs. So that's one example. Another example is I told you my mom got infected with TB when I was young. So obviously I was exposed. And when I grew up, with the increase in understanding of TB infection dynamics, I had the guts to go for TB testing when I was in college, which is difficult to do when you're just fit and healthy and you have no symptoms. Out of nowhere, you just think I'm gonna go for a test because of stigma. Its association with HIV and AIDS and stuff. So I went. I did a sputum smear microscopy test. I did a smear culture test. They were all negative. So I was happy. I didn't get tested positive. And then when I moved to the United States for my PhD, it was a requirement for every student who gets enrolled in medical school to get the gold quantiferon test. That was the first time I heard about it. In Zimbabwe, there's no test like that. If you need to do that, you need to go to South Africa. So I heard that and I tested positive. So now you can see a big difference, and I received treatment for that. You can see a big difference. I got exposed, got infected, but the TB was latent because probably my immune system was still competent enough to suppress it. But when an opportunity comes, when my immune system gets suppressed, it's going to reactivate. And by the time it gets detected, I might have infected 1 or 2 people. So it's difficult to control. So insufficient focus on drug-resistant TB is another gap that I see, especially in the resource-limited area.
That is a fascinating story. Thank you so much for sharing that. And again, what we're seeing is like, one part of the world has access to the latest, the greatest, the best, the most accurate, and then the other part of the world, and let's say it's probably the part of the world that needs it most, doesn't. And so it's this mismatch between what is available and where it's needed.
Mm-hmm.
Charity, I wondered if I could ask that same question of you. So some of the biggest gaps, and I know you bring like that clinical pharmacy experience, so interested to hear what you have to say.
Yeah, just really to agree with what Petra and Ferris has said and what you also highlighted, and to say that even within countries, even within low and middle income countries, the haves have access, and then the have-nots continue to not have access. And this is the most painful part of the work that we're doing, right? You have, well, there are gaps in development of tools. We want to see tools that are easier to use, tools that can be decentralized, because a lot of our services are centralized in hospitals that have fancy rooms and fancy staff, sophisticated technicians to do all kinds of, sophisticated tests that is not accessible to everyone, right? Like Ferris highlighted on, people might have to travel, maybe even across borders to get those kind of tests. So first, we need better tools. We need better medications that do not drive patients out of their minds, medications that are accessible to even young, patients, pediatric formulations, pregnant women, and all of that, because those people are not exempt from having TB. The fact that they were not included in clinical trials because of ethical issues, that's another big issue, right? Like, they are not exempt in the real world, they are not exempt. So why our tools excluding them in development? So we have all of these issues going on one hand, which I would say on the health system or on the research and development area. Within the health system as well, we have providers that are not suspecting TB, right? Like if I went to you and said, I'm coughing for 2 weeks or coughing for 1 week, not all providers would think TB right off the bat. They'll say, oh, maybe it's flu, maybe it's this and that, maybe it's this and that. And we saw that in the work that we did in Indonesia, Nigeria, and India between 2021 and 2023, where we saw patients on the other end of the health system part, where providers are not suspecting TB, going from one provider to the other, right? So we have providers within the healthcare system that either are not suspecting TB or do not have access to the right diagnostics or do not have access to the right medications. Now, how does this play out when we go to where the patients are? We see that the regular patient, the regular human being, if I started coughing, I'm not going to say, even in Canada today, that I have access to whatever world-class treatment there is. I'm not going to say, okay, I've been coughing for a week. Let me go waste my whole day at the emergency and wait to see a doctor. I'm not going to do that. I'll go to the pharmacy and buy cough medicine or something like that. It's the same way with this patient. They are not thinking, oh, let me go and look for the most sophisticated doctor because I have a cough. They are going to go to the pharmacy nearby. They're going to go to the traditional healer. They're going to go to the patent medicine vendor. They're going to go to their nurse that they know. So they're not thinking all of this stuff. So how do we get these services to where the patients are meeting providers? Because what we saw in that study was that patients were having anywhere between 2 to 21 encounters with different providers before they are tested for TB. Let that sink in. Let that really sink in, because this got me enraged. Imagine a regular patient that has very few amounts of money to spare having to meet 21 providers before they are tested. How many of them would even persist for that? A lot of them die before they get to that 4th, 5th, 6th provider, because the disease is ravaging their system, destroying their ability to breathe. And then you have them repeatedly looking for childcare, repeatedly looking for transportation, repeatedly looking for going off work or their businesses to go look for treatment, 21 different providers before they are tested for TB. And so when we say, oh, the Global Fund is funding treatment for patients and it's free, for these patients, it's not free. It's like months of losing work, leaving work and spending the whole day transporting to a facility, sitting there all day. These are the pain points in the system. Let's get the tools, let's get the sophisticated diagnostics and treatment to where the patients need it. Let's meet them where they are. Let's think patient, like Petra said at the beginning. Let's not think systems. Let's think patients first. Think about that patient that is not educated. Think, even in Canada, think about that homeless or housing insecure person that has to navigate a lot of systems to be able to get to treatment. I say this, that to us, we make this distinction, oh, they shouldn't have gone here, they should have gone there. To the patient, they try to meet a healthcare provider. They don't care whether it's a lab. They don't know what all these names we call ourselves are. They don't know who is a pharmacist or a patent medicine vendor. All the patient knows is that I tried to seek care 21 times and I didn't. So I feel cursed by the gods and I'm just going to wait till I die. Let's meet the patients where they are. Thank you.
Awesome.
Yeah.
Dr. Wolday, I saw you come off mute. Did you want to add something?
Yeah, okay. I agree with the other panelists on the diagnostic availability issues. Just to comment on Ferris's opinion that he can diagnose, I mean, like in Africa, like every clinic, in particular rural clinic, they use Zil-Nelson to diagnose TB. Not only we miss the drug resistance pattern of the mycobacteria, but the yield from Zil-Nelson is by itself inferior. You're going to miss like 65% of the patients. It have very poor sensitivity. So we're going to miss like 60% up to 65% of the patients. This is one of the major challenges, gaps treating patients in low-income countries. What does it mean? It means that, you have got a patient with chest problems, coughing, then it's a trial and error. We just give antibiotics. It's like shooting in the dark, as we say. Then we expose the patient unnecessarily to unnecessary medication, toxicity, with all the side effects, economy, time, and the TB gets worsened. It's masked. Again, we contribute to the late diagnosis. At the end of the day, the patient is referred or the sample is referred to a place where gene expert or culture is available only in the big cities, reference labs. And then until the result comes back, it's too late. As Charity said, maybe after a month, 2 months, culture especially takes a minimum of 3 weeks to get a positive result. These are some of the bigger challenges. Other bigger challenges, dealing with multi-drug resistant TB. Now we know I'm engaged in EDCTP, the European country clinical trial development, where we have a very great results from clinical trials, short regimen, all oral regimens, ultra, fast, short regimens are available, but they are not accessible. So accessibility is another major challenge. Additional major challenges, including, the United States pulling out of the WHO and so on. So, the R&D, research and innovation related to TB is also going down. It's less funded compared even to malaria and other diseases, HIV and COVID, despite the fact it's one of the major infectious diseases at a global scale. And also even, like places in Canada, TB is reappearing, re-emerging. I know from last year's data around Ontario, there were more than 450 cases. It's serious. So, all these things together, the gap is huge. Pediatrics, TB management is huge. Even, routine expert doesn't yield as good as in adults in pediatrics. So we need innovative tools among the pediatric age group as well. So these are all the challenges we're facing right now.
I think that's wonderful that you brought that home. I just came back from Nunavut, where PIH is going to be supporting tuberculosis elimination work, and Nunavut has, listen, I'm not sure if it's the highest right now. Petra, you might know better than I do, but it has some of the highest rates of tuberculosis. And it's a disgrace. It's a disgrace. I'll say that, leave it there. One of the things I want to make sure we have time for questions. So there is a lot that we didn't cover with our panelists, but one of the sort of takeaways that I want to leave our participants with is this idea of innovation. Innovation is a term that seems sexy, and it can be, but often innovation is really most effective when you are looking at the real problems and saying, what are the solutions to these? All of the problems that we've heard about today are rooted in inequities, and they relate to power and people and distribution of resources. And so I want to challenge you guys as you go and you leave and you think, how can I apply these to the work that I'm going to do and the innovations that I hope to make, to bear that in mind. It's look at the person who has the disease first and look at what is preventing them from accessing the care that they need. It might be a matter of reproducing a system that already exists, bringing it to a new place, expanding something. We might not need something new. We just might need it to come to a new place. So I wanted to do a lightning round with like one final reflection. Why don't we do questions, and we'll see how things go. So I turn it over to our moderators. Are there any questions that are coming through?
Yeah, if anyone has a question, you can feel free to put it in the chat. You can raise your hand. Go off mute. It's up to you, however you want to.
One question coming through. Okay. Thank you, Saira. Building on PH's longstanding commitment to community partnership and long-term support, what approaches do you see as most promising for expanding equitable access to TB care, especially for people facing geographic, economic, or social barriers? And as programs grow across diverse settings, how can public health teams thoughtfully integrate local culture's belief and the reality of TB-related stigma to ensure that care is both effective and deeply grounded in community leadership? This is a brilliant question. Who wants to take it? Why don't Petra, can I throw it to you?
Yeah, just a simple question. Thank you for that. And actually, I want to follow on where you left us, Marley, because the question actually is a really thoughtful, not necessarily asking about innovations, because that is and innovations in the sense that we think about innovations, which is tech. We often think about tech as solutions. I think that this question is asking the much more complicated systemic questions, like the integration of where do we need to be to actually address the stigma, or where do we need to be to get into the community and to actually reach the people. That is what the question is about. And I think it's really complicated what we have seen in TB programs, and it's linked to all the way the global health architecture is, and our national health architectures were built in silos. There is a TB program that is started at the national level, often goes only to the public health facilities, as Charity talked about, and Dawit also talked about. Where we need to be is at the community level. We need to be at that primary healthcare level. We need to be grounded into integrated services, because when we actually reach those pharmacists or the village health worker or the person who is embedded within the community, they have the trust. They can debunk stigma. They can work in a way that is respected in the local cultures, because those are the people that are part of the community. But the problem is that the services and the innovations and the technologies that we have, they stay in the public system somewhere in a larger facility. And so again, it's that same issue. Like, how can we create these disconnects? How can we bridge these complications of making sure that the program innovations really get towards that lower community-based level? And I mean, this is where I think just linking it to the bigger discussion right now that we all hear about the defunding of global health. It can be really feeling as a daunting issue where is our place? Where is your place as young students when you are just starting to enter that? I think maybe in our mind, we need to shift that around, that it is also a very exciting time because it means we can rebuild something new that really is more appropriate and that is multisectoral, that is looking at integration, that is looking at starting up from the community and from the patient instead of from the technology or from the provider point of view. So I think to bring that a little bit of hope or kind of positive injection in your question, it is possible. We have some really good examples that are really community-led, whether it is community-based services that are with vans or that are engaging with apps, the local providers. We have great examples on how pharmacies are supported by riders that are picking up sputum tests for TB. So there's lots of excellent examples that it can be done, but those need to now be scaled. And so that is a long-winded answer to your question. And I think we need a lot more experimental work and innovative local-based solutions to get to answer your question properly.
It's wonderful. I think Charity had mentioned, a lot of the research, there are ethical restrictions that prevent so much of the research on happening in communities that have the highest burden of tuberculosis. And also just like speaking to when you mentioned, Petra, the need to figure out what works, that's another consideration. Let's do the research in the global south or wherever there's the highest burden. Can you share an example where a technically strong TB intervention struggled because it did not align with local realities or community priorities, apart from patients having to see multiple healthcare providers before finding a solid answer? Maybe Dr. Wolday or Charity? Dr. Wolday, do you have an example? Or Charity, please go ahead.
Yeah, one example that jumps to mind is technology, anything that relies on electricity or internet service, and taking it to grassroots communities where they probably have 1 hour of electricity in a week, or they have to buy diesel to power a generator, or internet service is paid for out of pocket, and it's just you buy maybe $20 internet and you put it into your phone or into your computer, and within an hour it's gone. So when we think, real big helpful technologies, think about those end users that probably don't even have access to the basic computer or whatnot. But then the world is moving really fast. So what do we do? These are some of the questions that we're also grappling with as researchers and implementers. What do we do? The world is moving fast. Some of the best technologies out there need internet service, need electricity, need computers, need phones. And some of these end users struggle to have even those basic technology tools. So I know in the interest of time, I'll just stop at this example. Yeah.
That was a great example. Dr. Wolday.
Do you want me to add?
Yeah, in a 30-second tidbit. Yeah.
Yes, I agree with Petra. If you don't engage the community, nothing is going to work. Simple example, not TB. I can give you another one. We were engaged with some guys from the Nora Foundation in deworming, treatment of helminthic infection. At school level, we were deworming like 20,000 kids. We give them the tablet, nothing happens. The prevalence was very high. It was not working, the intervention. Then we asked the community health workers. Then we found out that the drug was not, it was just dumped in the field. Then the elders thought that we were giving pills that's going to prevent childbearing. They thought it was, and having children, a lot of children in this community is very important. Then we summoned the elders, we discussed with them. We took the tablet ourselves to show them it is safe, it can be taken. And later on, it's kind of miracle. We really dewormed like up to 40,000 kids in a year. So community engagement, we always forget that. And what we do is we write a proposal, we engage communities at the end of the proposal or project. No, we need to co-design the project from the inception. We need to get their feedback. We have to make member of the, like we need to have a community advisory board and so on. I can talk a lot on that, but this could be a very good example from my experience.
That was an awesome story. I know we're 1 minute over time, but Ferris, I don't know if you wanted to have the last word. We hadn't come to you in the Q&A, so just one final thought.
Yes, thank you. The only thing I would say, like to stress what Charity and everyone else has said, is innovation in the context of resource limited settings is not always like high tech. It's about appropriateness, simplicity, sustainability. So in some cases, you don't need to come up with a rocket science kind of an idea, which is happening right here. You get into seminars, people are presenting these brilliant ideas, but then you think, what are these ideas going to solve? So one big advice is stay close to the people that you intend to serve. I'm happy that you, Malay, from your experience from Lesotho, you can tell that some of the things that people here are trying to address are unrealistic. They are far from the problems that the actual people on the ground are facing. So get close to the problem, see what the problems are being faced on the ground, and then you can come up with the best idea. And another thing is, if you're a scientist who is trying to come up with an innovative idea, try to build interdisciplinary skills. Public health challenges don't need you just to be scientific. You need to have ideas about policy, economics, implementation science, and community engagement. They are just as critical. So that's my last word.
I am so glad I turned to you. I think that is an incredible way to end. I don't think there's anything to add other than perhaps to say thank you to our panelists. This has been such a delightful conversation, and I really appreciate all of the perspectives that you guys have contributed to it. I appreciate the team from McMaster for organizing this event, my PhD colleagues for helping coordinate and lasso me into being here. And you, the participants, guys, this has been delightful participation. Thanks for those questions. If you have any additional questions, please feel free. I'm going to say either email the McMaster team or the PH team, info@phcanada.org. Add us on LinkedIn, do the whole deal. Let's stay in touch and turn it back over to you. I think, Verena, do you want to? You're on my screen, so I'm handing it to you, but anyone. There you have it. Thank you.
Yeah, I think at this point, anyone that's part of the case comp, wonderful panel, by the way. I learned so much. So anyone that's ready to carry that learning over into the case comp can stay behind, and Allison will introduce the case comp. But thank you so much to the panelists and everyone that joined us for that part of it.
Thanks, guys. I'll be heading out, but good luck in your case competition. They're so fun. Enjoy it.
Okay.
Cheers,
Okay.
guys.
Bye.
Yeah, good
Bye.
luck,
Thank you.
everyone. Bye. Yeah.
Okay, thank you so much, everybody. That was an amazing panel to kind of get us started for our case competition next week. My name is Allison. I am a Programs and Youth Engagement Officer at Partners in Health Canada. And I'm just going to give kind of a bit of background information that you will need for the case competition on Friday. So the purpose of a case competition, for those of you that have never been, basically you'll get introduced to health issues kind of from a biosocial perspective, and you'll understand the root causes of some inequality and illnesses. And then you'll come up with a solution to a health issue in one of the countries where we work. So you'll work in teams of 4, and you'll come up with a solution to the problem of tuberculosis in Lesotho. Obviously, that's a huge ask. We're not asking you to solve tuberculosis in Lesotho, but you'll get a specific problem on the day of, and you'll be asked to come up with a program that will work. And just a note, if you have registered individually, you'll get put into a team on the day of, so next Friday. So don't worry about that. I am going to drop a link in the chat. I was going to drop files, but I don't know if it will let me. So I'm going to drop a link to a Google Drive in a bit. Let me see if I can do it now. Okay, that should work. So in the Google Drive, there will be 2 main files. So there's the TB info package, and there's the McMaster TB in Lesotho case info package. And that has all the information that you'll need for Friday. So it has background information on tuberculosis, and it also has background information on Lesotho's health system and kind of the social determinants and structural factors that have created the situation that has allowed tuberculosis in Lesotho to remain so rampant, and why the situation is the way it is. So there's also another folder called additional resources. And these are files, they're not required for you to read, but they can kind of help you dive a bit deeper and get a better understanding of the lens that we want you to be looking at the problem from. And they could be super helpful. So they're more so kind of readings related to health inequities in general, social determinants of health, kind of the lens that Partners in Health uses when it designs programs for tuberculosis and other health problems in general. So you'll have a week to go through this information at your own pace. You can let it resonate, do some more research if you want to. And then next Friday is when you'll actually get the case, and you'll actually get to start working on the solution with your team. So you don't have to do any work this week. It's really just to kind of let you have time to understand some complex topics, because we found before, one day isn't really enough to grasp all of this stuff. So this is just to kind of get you to have time to do this at your own pace. And then on the day of, you'll have, I think, roughly like 3 to 4-ish hours with your team of direct work time where you can come up with a solution. And then there will be a panel of judges who I think will all be from Partners in Health Canada, some of who have direct experience in program management in Lesotho. You'll present to them, and then we'll announce winners based on your presentations. But yeah, that's kind of the bare basics. If anyone has any questions, totally feel free to pop them in the chat or raise your hand or just blurt them out. But it's really just this Google Drive and those 2 documents to help you kind of understand what you'll be doing on Friday. I'll just wait a few seconds to see.
Okay, there's a few questions. What's the parking like at McMaster? Where can we park? I guess I can answer that. So parking on campus is a bit expensive, but street parking, you can take a chance with it. There's a 1-hour limit. Otherwise, you could park underground at the hospital. I think that's like the cheapest place where you can park. And there's like 2 entrances. So if you type in the address as McMaster Children's Hospital, it'll take you to either the Forsyth underground parking, or it'll take you to the other parking where you go around the hospital. The Forsyth one is easiest to access, and it's the closest one to the clinic where the case comp is being held.
And we can pop a little blurb, like we can send a summary email after with a little bit of some more information about parking for those that are driving.
Yeah, we'll send out an email before Friday just with information about location, the agenda again, just so everyone has it. I see another question about the presentation. You can present it however you want. Most people do make slides, but if you want to just do a pitch, you can totally do a pitch as well. And another one about attire, you can wear whatever you would typically wear to school. That's totally fine. You don't have to be business or anything.
I just want to add to the presentation. As Allison mentioned, you can use, whatever visual aid or other you want. But similar, because I see another question on the program following a certain structure, and I wanted just to say that additional resources related to the case itself will be made available on the day of. I do see some participants who have participated in previous case competitions. Hi, by the way. And so similar to that format in the past, you will have the case details as well as the rubric that you will be judged by. You will have that with you, and then that can sort of guide how you want to structure your program. And then also you will have some material like photos and things that you can source and utilize in your presentations.
And for the time for the presentation, it will probably depend on how many people sign up because we are on a limited time in the room. But typically they're around 6-ish minutes. So it's kind of like a pitch style. And for those who signed up independently, you'll be assigned your group on the day of.
I'm gonna put the email again in case anyone has any questions, like as they come up after. Okay.
Okay, if no one has, oh, there's a few more. Okay. Yeah, the event space is open from 9 to 5. I think there will be a bit of time for registration coming in. There will also be a keynote speaker that will take up some of the morning, and then I will present the case, or someone from PIH will present the case to you, which will take a bit of time as well. So you'll probably be working on the pitch from around noon to 3:30, depending on how many people are there, and then we go into presentations and judging. The presentation portion of the event, it depends on how many people are there again. It's typically, I would say, an hour.
I'm also putting these questions on a doc and I will share it and I'll put it in that Google Drive, just some FAQs that were asked.
Yeah, if anyone has any questions, totally reach out beforehand. But we'll also be there the day of, like, to help out with anything. If you have questions about the case, if you have questions about tuberculosis, we're there and we're there to help. Okay, if that is it, I think we can let you all go. Take a look at some of the documents. Oh, does someone from maybe want to talk about the certificate?
Yeah, we just wanted to acknowledge like people that were able to attend. So like we have a little certificate for those that were able to come and have their cameras on for a good amount of it at least. And I think we're gonna be trying to get those out as soon as possible, but bear with us.
And I think we're also doing a certificate for the case competition.
Yes.
Yeah. So you'll get a certificate for participating in the case comp.
And to answer the question on the panelists being the judges, unfortunately not, because a couple of them are not in Hamilton. But yeah, we will keep you posted because I am honestly so inspired by today that I want to ask if maybe they would come and and judge as well on the day of. But obviously, since we have not asked them yet, we cannot confirm on their behalf.
Okay, I think we'll wrap it up here and let people look at some of the content. If anyone has trouble getting into the Google Drive, I'm going to put my email in the chat and just email me. Yes, but we're so excited to have you guys next week and meet all of you and hear all of your ideas. Case competitions are super fun, super exciting for us too, to hear all of the new ideas that come out. So thank you so much for attending, and we can't wait to see you.
Thank you, everyone.
Thank you. Bye.
Thank you.
Thank you. Bye bye.